Welcome to the Research Overview Cystic Fibrosis-Related Diabetes webinar hosted by the CF Foundation. We are so excited to have you, and we're looking forward to discussing some current and upcoming research that's happening in partnership with the Foundation and endocrinologists across the country. My name is Megan Helmick, and I am an adult with CF, and I have CFRD, and I also live in Virginia.
And hello, welcome. I'm Michelle Quintana. I am a mother of 2 of 3 children with cystic fibrosis, and they both also have CFRD.
We're going to get started with our first presenter today. Tony is going to give us a brief overview about what CFRD is, and then go into some of the research that she's been involved with.
So, hello everybody. Am I on? I don't see myself. Okay,
Yes, you're on.
That I'm on. I'm not seeing it, but welcome. I hear there are about 500 of you out there watching this webinar, so I'm thrilled that there is so much. I am going to start out with a very brief introduction, a very basic introduction to CFRD. What is it? What's insulin? And then I'm going to start the discussion of the various research projects that we're all involved in. So next slide, please. Okay, this is a picture my sister made for me 30 years ago, but it explains what insulin is and how it works. So on the left side of your screen, you see a big intestine, and then horizontally is a vein, and those little dots are the glucose from the diet that enter the bloodstream. Your bloodstream carries glucose to the cells. Blood doesn't need glucose. It's the cells that need glucose. Next slide, please. The problem is that glucose can't enter the cells on its own. So this yellow organ is the pancreas, and inside all those little keys represent insulin, because insulin is the key that you can think of as opening up the cell to allow the glucose in. If you don't have enough insulin, if you don't have enough keys, or if the key doesn't work, and that's called insulin resistance, then the sugar will just stay in the bloodstream. You'll have a high blood sugar, but the cells of the body will be starving. So diabetes is when there is not enough insulin or the cells don't let the insulin in. Next slide. So what happens when you don't have enough insulin? This is a picture of someone with type 1 diabetes, but it illustrates the point. This is an adolescent young woman who presents without any insulin. She gets insulin, and you can't even recognize her as the same person. She's wasted beforehand, and she just looks healthy afterwards. So there are 2 problems when you don't have enough insulin. That high blood sugar sitting in the bloodstream causes problems. That sugar has to go somewhere, and so it goes out in the urine. You have excess urination, that makes you thirsty, it's hard to keep up, you get dehydrated, low energy levels, bacteria love all that extra sugar, so there's increased risk of infection. And over time, we see complications of diabetes of eye, kidney, and nerve damage. But also important, and something that is perhaps not talked about as much, is that it is also not a good thing to have low insulin levels. And this is particularly relevant in CF, because without enough insulin, you break down your fat, you break down your muscle protein, you have trouble with weight loss, trouble gaining weight, and in particular, reduced muscle mass, and in children, poor growth. Next slide. So what are the types of diabetes? So type 1 used to be called insulin dependent or juvenile onset. This is the most common type in children. These people make no insulin because every single cell making insulin has been destroyed, and they have to take insulin to survive. Type 2 used to be called insulin independent or adult onset. People with type 2 diabetes make some insulin, but not quite enough. And also, insulin does not work well in their body. They're insulin resistant. These folks can often be treated with drugs other than insulin. They're usually obese, have high cholesterol, high blood pressure, things that are not typical of CF. And then there's CF-related diabetes, which is its own category. People with CFRD make some insulin, but just not quite enough. But they are sensitive to the insulin they make unless they're sick. Next slide. We know that the majority of CF patients will develop CFRD. This is just part of CF. This shows different age groups. On the lower left, starting with children less than 10 to 19-year-olds, etc. So, and the prevalence or the percent of people at that age group that have diabetes. Children, not very common. Adolescents, about 15%. People in their 20s and 30s, about 40%. Over the age of 50, about 50%. But in fact, those with severe genotypes, especially the Delta F508 genotype, over 80% of them eventually develop diabetes. So this is just part of CF. Next slide. These are, this is how we look at those oral glucose tolerance tests that people with CF take every year. It's a 2-hour test, so you see time along the horizontal axis. And then we look at the blood sugars. And there are categories. If you look on the right side of your slide, and actually if you start on the bottom and go up, there's normal glucose tolerance, where the 2-hour level is less than 140. There's indeterminate glucose tolerance, where the 2-hour level is normal, but the 1-hour level is high, up there above 200. Impaired glucose tolerance, where the 2-hour level is between 140 and 200. And then you have diabetes that initially starts out with normal fasting or first thing in the morning glucoses, and eventually even those are high. So you can think of this as a fairly steady progression over time. Next slide. And here's a different way of looking at that, from normal glucose tolerance to diabetes. So we start out with someone who has completely normal blood sugars. That's actually pretty unusual in CF. People whose blood sugars are normal on their oral glucose tolerance test. Later, we're going to talk about CGM or sensors. Most people with CF, if you have something on that measures your blood sugar all the time, shows that there are little blips in blood sugar. At the far end are people with diabetes. But one of the more interesting groups, or the group that we're not really sure what we should do with, is that group in the middle. Next slide, please. Okay, so the group in the middle, the indeterminate and the impaired glucose tolerance together, those are called abnormal glucose tolerance or pre-diabetes. We know that people on the far left are generally clinically stable. We know that diabetes increased risk in CF, increased risk of worse lung function, malnutrition. It's that group in the middle where we're starting to see increased risks, and yet the blood sugars are not that bad, not the kind of blood sugars where we would normally think about starting insulin. But the insulin levels are low, and that may be affecting other things that are bad for the health of people with CF. Next slide. So that actually leads into one of my main research projects. We know that non-diabetic CF patients with abnormal glucose tolerance are insulin deficient. Insulin deficiency leads to protein or muscle breakdown. Muscle breakdown is associated with worse pulmonary function. So should we be giving people with CF and abnormal glucose tolerance insulin replacement to preserve muscle mass? And honestly, if insulin was a pill, if it wasn't something people were a little bit afraid of, we would probably be replacing it right away in the same way as we replace vitamins and everything else. But insulin is not a pill, and it does have some problems. So the primary hypothesis of this research is that in CF patients with abnormal glucose tolerance, daily insulin replacement therapy will decrease muscle breakdown. Next slide. So this is a picture of the study. If you start out in the middle looking across the bar there, there's a 2-week baseline period, and then there is a 6-week insulin therapy period. And basically, first we take 2 weeks and measure how people build up and break down their muscle. And then we put them on insulin for 6 weeks to see if it improves. And we are very much hoping this study will help us determine whether we should be treating people with abnormal glucose tolerance. It was supposed to be done by the end of 2020. We have had to go on hold with research. I'm hoping by next summer we'll have the results. Next slide. So the other thing I want to highlight is the Envision program. This was launched in 2016. The CF Foundation recognized that there are not a lot of endocrinologists who know much about CF endocrinology. So we started training 16 mentees from around the country. There were 5 mentors, including people on this webinar today. Half of the mentees were pediatric endocrinologists, half adult. We gave them 20% protected time for CF. That means the CF Foundation paid 20% of their salary to free them up so their institutions wouldn't make them do other things, to let them just work on CF. And they established local CF endocrine clinics. There was mentorship to get them involved in research projects. There were webinars. The program was very successful. All of these people are still working in CF. Next slide. So based on that success, we just started a new cohort a year ago. We have 20 new mentees. Some of the former mentees are now mentors. There are 4 senior mentors, 6 junior mentors. All in all, between both of these cohorts, there are 30 new endocrinologists who are interested and knowledgeable about working in CF. Next slide. And this just shows the geographic distribution of the first 2 cohorts. We've got 2 more years to go on this cohort, and we will probably do it again, and we will be trying to fill in some of those other areas of the country that are less well represented. Next slide. And with that, I am going to turn this over to Dr. Andrea Kelly from Children's Hospital of Philadelphia, and she will tell you some of the really interesting work that she's involved in.
Great. Thanks, Tony. Before reviewing some of the ongoing and recently completed research in which we're engaged, I just wanted to acknowledge Tony's great contributions to not only the clinical care of people with CF-related diabetes, but to our understanding of CF-related diabetes through her great research, as well as the tremendous mentorship that she has provided to many of us that has allowed us to continue in this field. Next slide. So just to start, PROMISE is a large multi-center CF Foundation funded study aimed at examining the impact of clinically prescribed Trikafta on multiple outcomes. The study was initiated in late fall 2019 after FDA approval of Trikafta for people with CF age 12 years and older. And because improvements in diabetes have been reported with treatment of ivacaftor, a natural question extending from that observation amongst clinicians, researchers, and many of our patients is, does abnormal glucose tolerance and diabetes improve with Trikafta treatment? And so for an endocrine sub-study that I'm co-leading with Mike Stalvey at University of Alabama, we're completing oral glucose tolerance tests at baseline, 12 months, and 24 months after the start of Trikafta. And what we'll be examining is glucose tolerance as well as insulin secretion. And we'll also be looking at DEXA for bone and body composition, meaning how much muscle mass someone has and how much fat someone has. And in our younger population, we'll also be looking at how well they're growing and how well puberty is progressing. Next slide. A similar CF Foundation funded study referred to the BEGIN study is about to start. Just by way of disclosure, I am only peripherally involved in this study, and Dr. Mike Stalvey is spearheading the endocrine initiative. And for this study, toddlers with CF are the focus through a natural history study. And the assumption is that at least a subset will start CFTR modulator therapy during the course of this natural history study, which is referred to as BEGIN. We also know that blood sugar abnormalities have been seen in toddlers with CF. And so Mike has organized a sub-study for a subset of toddlers in the BEGIN study to examine continuous glucose monitoring. Briefly, this tool measures blood sugar continuously through the day and night. And I'm not going to speak about that to any great extent. My colleague, Dr. Bryn Marks, will share a lot of information regarding that during the next presentation. Next slide. Our group at CHOP and Penn has been really interested in how insulin secretion defects progress and glucose intolerance emerges over the years in people with CF. And our goal or our hope is that a better understanding of the mechanisms and risk factors associated with worsening glucose tolerance will permit interventions to interrupt progression and even delay or hopefully even prevent CFRD development. So for this ongoing study that's been going on for about 5 years now, and that we're planning on for another 5 years, we're collecting glucose tolerance test data. We're measuring glucose, insulin, and other hormones during a meal, and in response to a high blood sugar during a specific test called the GPA. Some of the potential players that we are considering include family history of diabetes and type 2 diabetes related genetic factors. So we've actually collected blood for DNA, body weight, physical activity and exercise, CF pulmonary disease and inflammation, as well as CFTR modulator therapies. And again, we're getting DEXA so that we can better look at not only the impact of body weight, but also body composition, how much fat and muscle mass one has, and that relationship with glucose abnormalities. My colleague, Dr. Kilberg, whom we thought was not going to be able to join us, but who is here today after delivering a beautiful baby boy just a few days ago, has been working alongside us to study the hypoglycemia, or what you might know as consider or think of as low blood sugar that frequently occurs after meals in people with CF. And her data suggests that hypoglycemia after meals is an earlier sign of abnormal insulin secretion in CF. Next slide. Our team has also been asking about the role of type 2 diabetes medications in CF. And patients often ask us if insulin treatment is the only option, because multiple insulin injections a day already adds to what is often considered a burdensome daily regimen. And as Tony has alluded to earlier, insulin deficits are really the hallmark of CF-related diabetes. And as a result, not all type 2 diabetes medications would be appropriate in CF. But some, like the ones we are studying, are attractive because they may be taken by mouth or by injection just once a week and are thought to directly promote the health of the cells that make insulin. Next slide. So let me first extend a little bit of Tony's introduction with a brief, although admittedly oversimplistic review of insulin secretion. When we ingest food, the intestines secrete hormones called incretins, mainly GLP-1 and GIP. And these hormones, in addition to blood sugar, act on the pancreas to stimulate insulin secretion. And GLP-1 also decreases glucagon, which is a hormone that increases blood sugar and is also tends to be high in type 2 diabetes. There's an enzyme known as DDP4 that causes the breakdown of these incretins. Next slide. Sitagliptin is an oral type 2 diabetes that inhibits this enzyme to increase levels of these incretin hormones, to augment insulin secretion, lower glucagon, and ultimately to lower blood sugar. I also should acknowledge that there's some evidence that incretin secretion is reduced in people who need pancreatic enzyme replacement in the setting of CF. So the use of sitagliptin is attractive if you can augment this incretin secretion. Next slide. So to study that a little bit further, we completed a 6-month trial of sitagliptin in 24 people with abnormal glucose tolerance or early CF-related diabetes. And we measured glucose, shown here in the left-hand panel, and this is very similar to the glucose tolerance slides Tony showed earlier, and insulin secretion shown on the right panel. And this is in response to a meal, not a glucose tolerance test. And to give you a sense of what this looks like, in the gray shadowed area are people without CF who have normal blood sugar. In green are people with CF and normal glucose tolerance, and you can see that even individuals with normal glucose tolerance don't quite have perfectly normal glucose. In purple are early glucose intolerance, orange impaired glucose tolerance, and in red CF-related diabetes. And hopefully what you can appreciate is that increasingly higher blood sugars after the meal occur as the glucose tolerance worsens. On the right-hand side, you can see with worsening glucose tolerance, moving from green to purple to orange and then finally red, insulin secretion is lower, particularly during that first 30 minutes after the meal. And so we're really quite interested in that early insulin secretion as part of our research. And so what we wanted to see if we could lower glucose, that green arrow on the left-hand side, and improve that very early insulin secretion, that blue arrow on the left-hand side, during a meal with 6 months of sitagliptin. Next slide. 6 months of sitagliptin was well tolerated, but what we found is that it was not very effective in improving insulin secretion or blood sugar following a meal. Next slide. We wanted to understand this a little bit more closely, so at the same time, we were actually infusing through an IV, either in a separate study, either GLP-1 or GIP, so we could see the direct effects of these on augmenting insulin secretion in people with CF and abnormal glucose tolerance. Interestingly, GLP-1 infusion got a really robust insulin response, but GIP had no effect on insulin secretion. We know that this resistance to GIP is seen with type 2 diabetes. We don't know why that happens in type 2 diabetes. It's not seen in people with prediabetes who don't have CF. And so we don't know why this is occurring in people with CF with these early glucose abnormalities. We really don't know if this resistance to GIP is actually a feature of CF. Next slide. But this really nice insulin response to GLP-1 is promising. So in our next study, we'll be directly testing a GLP-1 based therapy, and that's referred to as dulaglutide. And we'll be trialing this for 6 weeks. This is a type 2 diabetes medication, and it's attractive because it's given by an injection just once per week, although it may have some GI issues. So what we'll be monitoring is GI issues in addition to the impact of this therapy upon insulin secretion and blood sugar, using that same mixed meal that I showed previously, and looking at glucoses shown on the left-hand side and that insulin secretion, specifically that insulin secretion in that first 30 minutes. That study will hopefully start in the fall. We've been delayed a little bit by COVID. I think these studies are really important because while we hope that highly effective CFTR modulator therapies improve blood sugars and insulin secretion for the vast majority of people with CF, diabetes will remain a challenge for many patients. And I should also acknowledge the many patients at our center have committed the time and effort to help us better understand CF diabetes and consider potential intervention strategies. Next slide. Next slide. And with that, I would like to, next slide. I would like to introduce Dr. Bryn Marks from Children's National Medical Center in Washington, D.C. Thanks, Bryn.
Thank you so much, Andy. I really have the pleasure tonight of sharing with you some research that's been a tremendous collaboration between all of the endocrinologists who you're hearing from, as well as Dr. Kilberg, who is home with her newborn, plus the CF Foundation Community Voice, and hopefully some members of the audience tonight who have helped us with this project. Next slide, please. So as clinicians and as researchers, We all had our areas of interest, and we started off by exploring those areas through some focus groups. So in those focus groups, we included both adults and parents of children with CF, and we included both people with CFRD and without CFRD. And we took the information that we learned from those focus groups with a relatively small number of participants and used that to develop a survey that was actually just released through Community Voice and was active from May 26th to June 4th. So this is fresh off the presses. Tonight, you are the very first people to be hearing about this data. We got 120 responses, and if we can move to the next slide, I will share some of that with you. So the first area that we explored was education about CFRD. And from our focus groups, there were a few themes that came through loud and clear. We heard from you about the challenges of managing two chronic conditions, trying to navigate diets that are seemingly opposed for CF and for diabetes, the time commitment, the coordination that it requires. And then, as Tony mentioned, we also heard about the need for CF-specific endocrinologists. We know that we are not an easy group to get into, and I think difficulty in accessing us for care led to some of the challenges of learning about CFRD, and a theme that I think was sort of best summed up with a quote of "figure it out as we go." Next slide, please. So from there in the survey, we explored when people actually learned about CFRD from their care teams. So what you can see here is a pretty even distribution of data. So some people learned about CFRD during hospitalization. Some people learned as they were starting to do their annual OGTTs. Others didn't even learn about CFRD until after they were diagnosed. And I want to contrast that with, next slide, please, what people described as when they wanted to hear about CFRD. So what you can see here, the purple dots represent the combined data from everyone who responded. The red dots are the parents, and the green dots are the people with CF. So most people, 41%, expressed that they would be interested in hearing about CFRD before they started the annual OGTTs. And that was particularly prevalent in the parents, with 60% of them expressing that interest. From there, other folks were interested when they actually started the OGTTs, others not until there were abnormalities in OGTTs. Next slide, please. We then started to think about how do people want to learn about CFRD. So here, it wasn't surprising for us to hear that most people wanted to hear about this from the pulmonary team, the folks that have known you and cared for you for a prolonged period of time. So 62% of people indicated a preference for the pulmonary team, and then 43% were interested in hearing about it from the endocrine team. And what was refreshing to see in this era of online webinars and Zoom meetings is that most people are actually interested in hearing about this face-to-face. Next slide, please. So in thinking about what sorts of educational initiatives we should be working on to get the word out about CFRD, again, that in-person education was a really prevalent response. Others are interested in more formal educational materials, whether that be online or through pamphlets, and then less and less people interested in mentoring from peers and online webinars like we're doing tonight. So apologies, hopefully this is still interesting for you. Next slide, please. Next, I'm going to shift into the second theme that we explored, and that's diabetes technologies. So we are still in the process of analyzing all this data from the survey, so I don't have anything to report for you now, but what I'm going to do instead is to give you an overview of the technologies. So the first thing to talk about are continuous glucose monitors. So what these devices do, they sit just under the skin, and they measure glucose levels constantly throughout the day. They send that information either to a smartphone or to a receiver, where you can see that glucose value at any point in the day without pricking your finger to get it. Next slide, please. And to capture the impact of these CGMs, I think the best way to do it is to show you some actual data here. So this is from one of my patients. The green X's that you can see there capture finger stick blood glucose values. And then those two blue bars that you see represent the upper and the lower end of the target blood sugar range. And on the x-axis, you start off at midnight and it goes through the day up to noon and then back to midnight. Next slide, please. So if we contrast those 3 data points versus 288 data points, or a glucose value every 5 minutes all day long, what we can see is that what initially looked like some pretty good blood glucose data is actually really worrisome for both high and low blood. Next slide, please. In addition to the sheer volume of glucose values that we get, we also get what are called trend arrows. You know not only where the blood sugar is, but where it's heading. Is it rising? Is it falling? Is it holding steady? And to go along with that, you also get alarms that can alert you to both high and low glucose values that you can then act on and treat accordingly. Next slide, please. The second piece of the diabetes technologies are insulin pumps. So what you have here are 3 of the most common systems that are on the market right now. Next slide, please. And I want to compare and contrast insulin injections versus insulin pump therapy. So on the left there, what you see are the commonly used syringes and pens that many will use for injections, and on the right is an insulin. So in these devices, they're filled with insulin. You do that yourself at home. It holds about 3 days worth of insulin. And then there's tubing that comes out of the pump and connects to that body at that white spot that you can see on the gentleman's abdomen. So just under his skin is a little tiny tube that the insulin actually goes through and is released into his body throughout the day. Next slide, please. With injection therapy, we often use 2 types of insulin, the first of which is a basal insulin. It's a background insulin that's meant to keep blood sugar steady when you're not eating. That's given once a day, and you sort of get the same amount of that insulin all day long. Next slide, please. What we know in reality is that people need different amounts of background insulin at different times a day. And with an insulin pump, we use what's called a rapid-acting insulin that's only active in your system for about 3 hours. So because of that, and because you're wearing the pump at all times, we're able to more effectively titrate the doses throughout the day. Next slide, please. The second part of injection therapy is also a rapid-acting insulin that would be given each time you eat or need to correct a high blood sugar. Next slide, please. And with an insulin pump, instead of giving an injection every time you need more insulin, you just hit a couple of numbers on that pump. You put in a glucose value, you put in how many carbohydrates you're eating, and it will do the math for you. You change that site on the belly where the pump is connected about every 3 days. So essentially you're using 1 needle to put that site in every 3 days as compared to a minimum of 4 injections a day for most people on injection therapy. Next slide, please. The other interesting thing that we can do with a pump is to deliver insulin over a more prolonged period instead of all at once, so that the insulin action better matches food absorption and that we can control blood sugar better. Next slide, please. So as I said, I don't have anything to share with you, but we are in the process of looking at that. Have more for you to come at NACFC in October. Next slide, please. And then finally, as researchers, we want to make sure that we're doing research that actually matters to the CF community. So one of the questions that we asked was, what areas of endocrine-related CF research are you interested in? So we take care of all sorts of hormonal issues, CFRD being the most common one. And not surprisingly, that was the most popular topic of endocrine-related CF research, followed closely by hypoglycemia or low blood sugars, and then nutrition and body composition, with a little bit less interest in bone disease and reproductive health. Next slide, please. And then finally, we explored what aspects of CFRD people want to hear more information. So as you heard from Andy, Trikafta and its impact on CFRD is a hot topic that we are actively working on with research right now. Other folks were also really interested in thinking about CFRD prevention and how to handle complications related to CFRD. Next slide, please. And with that, I'm going to hand it over to Dr. Hoffman, who is both an adult and pediatric endocrinologist in Boston, and is going to share with you some interesting information that combines continuous glucose monitor data to automate insulin delivery.
Thank you so much. So as Bird mentioned, I'm an adult and pediatric endocrinologist. I see patients in the CF centers at Boston Children's and in the adult CF program at Mass General. And I also do clinical research, primarily focusing on CF endocrine disorders, including CFRD. And I wanted to highlight one particular study that we're working on right now, which is the bionic pancreas in CF. Next slide, please. So the opportunity to take care of a lot of patients with CFRD has really shed light on, for me, on some of the unique challenges that our patients with this condition have to face. And these are the challenges that we're hoping we can address with technology. So the first one, and I'm sure everyone here is well aware, the treatment burden of CF alone is very high. And so when we add diabetes to that, the blood sugar checks, the insulin injections, the carbohydrate counting, this can really become overwhelming. In addition, people with CF have high calorie nutritional requirements in order to keep their BMI in a good range, because we know BMI is really important for lung function and other health outcomes. But what this means is that people have to eat, and they have to eat a lot, and they have to eat all the time in order to meet these calorie requirements, and that can make blood sugars difficult to control. In addition, insulin needs can be variable in people with CF, and they can change with clinical status. So if someone is healthy, they may not need a lot of insulin to manage diabetes. But then if they get sick or have a CF exacerbation or need steroids, then they can need a lot of insulin. And keeping up with this changing requirement can be complicated. And then lastly, low blood sugars we know are common in people with CF, even without diabetes. And so when we're treating with insulin, which can cause low blood sugars in people who already have low blood sugars, that can be also very difficult. Next slide, please. And so we hope that the bionic pancreas can help to address some of these challenges. So the bionic pancreas is a fully automated artificial pancreas device. So this means that basically this is a special insulin pump similar to what Bryn just described. And this pump is integrated with a continuous glucose monitor, or CGM. And so the CGM is checking blood sugars every 5 minutes and then sending that information to the device. And then the device is automatically adjusting the insulin delivery to keep the blood sugars in a good range. And this device can also give glucagon. And glucagon is the hormone that the pancreas makes to protect against low blood sugars. And so what this looks like is that when the blood sugars are high, the device gives insulin to bring the blood sugars down. But if the blood sugars start to go too low, it'll give glucagon to keep it from the low blood sugars from occurring. And so it's this constant balance between insulin and glucagon to keep blood sugar stable, kind of like what a pancreas does. One benefit of this device is that it uses machine learning to continuously adapt to the specific needs of each user. And so that means that the device will learn what a person needs, say, when they're healthy. And then if those insulin needs change when they get sick or need to go on steroids, the device will learn that too and will adjust itself to account for the changing continuously all the time. And I think that in particular is important for people with CF. And then also with this device, carbohydrate counting is not required. So for every other device that's currently available, the pump requires each user to count the grams of carbohydrates that they're going to eat and then tell the pump so that it can give insulin. But with this device, that's not required. And so it just makes things a little bit easier. Right now, this device, the bionic pancreas, is being studied in a multi-center phase 3 trial in children and adults with type 1 diabetes. Next slide. And we studied this device in a small pilot study in 3 adults with CFRD. And in this pilot, we found that the bionic pancreas was safe, it improved blood sugar levels, and most importantly, it just made diabetes a little bit easier. And help to reduce some of the burden of diabetes management. And that is why I'm so excited about bringing this device to people with CF. And so our next steps are we have funding from the NIH to do a couple of different studies. And one of those is a randomized clinical trial where we will test this device over a 6-month period in children and adults with CFRD in the Boston area. And then I'm even more excited that we are partnering with the CF Foundation, and we are working to expand this single center study to multiple centers across the country. And there are 3 reasons why I'm so excited about this multi-center study. So the first one is that this is going to really give us the opportunity to investigate, does this device, is it safe? Is it effective? Does it work? For people with CFRD across a broad range of ages, insulin requirements, health status, to really learn how it works. The second reason is that this trial is going to give us the opportunity to look and see how does really good blood sugar control over a 6-month period impact other things in CF, like pulmonary function, CF exacerbations, BMI, body composition, lean body mass. And then thirdly, we are in discussions with the FDA to find out, what would it take for us using this study to be able to get FDA approval for this device for the indication of CFRD. So right now, every other diabetes device out there, they're only approved for type 1 diabetes and type 2 diabetes. But if we can get this device approved specifically for CFRD, then we can use this as an argument to make sure insurance companies, or at least to try to convince insurance companies, that they should cover this device and pay for this device for our patients with CF. And so, next slide. With that, I'd like to turn this back over to our moderators, Megan and Michelle.
Thank you so much, Melissa. So we have a few questions that were pre-submitted for this webinar, and so I think feel free to put questions if you have them in the Q&A tab on this, but we're going to ask a few of those questions first. So this question I think is probably going to go back to Melissa, if you don't mind, or someone else is welcome to take it. But I know sometimes, and I've seen with like type 1 diabetes, that kids as young as like 6 or 7 are using a pump or a CGM. What is your guys' recommendation, or at what age do you think people that may be diagnosed with CFRD could actually start relying on that technology?
No, that's a great question. So for CGMs, they're FDA approved down to age 2. And so really young children can and actually benefit a lot from using CGM, and the same with insulin pumps. I think really the decision to use this type of technology, a lot of it comes down to how it would benefit each particular patient. And so I think I like to kind of take it on a case-by-case basis. Will having this information help to make diabetes easier, make monitoring blood sugars easier? But I think that really all ages can benefit from that. For our study with the bionic pancreas, right now for the study in type 1 diabetes, it's going down to age 6. And so I expect, we haven't decided for sure, but I expect that probably we will do something similar for our study.
Okay, good. Oh, I think that's supposed to be me. I apologize. I'm sorry. Again, this is Michelle, and I just actually wanted to mention that I didn't mention at the beginning that my 2 kiddos with CFRD are both 22 and 18, and we've seen so much has just changed in the past 10 years since they were diagnosed, and community voice can be a great resource. So with the CF Foundation's development of this entity for the CF community, it's been a great resource for us, and just getting the word out there, research ideas out there, education, support resources. So I just welcome parents and those with CF to look into that, and of course check out the CFF.org website. My question, which also came through from several registrants, as well as we're seeing a few that have popped up in the Q&A chat here, that I think Dr. Melissa, you can help with as well, is just the role of diet and nutrition. And as we know, and it's been a challenge with my kiddos, is that with CF, they have to maintain a high caloric diet. And whereas, before they were diagnosed, you never thought about carbohydrates and carb counting and managing that balance between the three. And then CFRD comes into play, and It's great to see now there's more being done to understand CFRD, that it's not quite type 1, it's not quite type 2. So how does that role of diet, where does that fit in, affecting CFRD, as well as some of the new types of, I don't want to say fad diets, but like the low carb, high fat, does exercise, all of that play into CFRD, maybe prevention or, just in maintaining and helping with CFRD?
Is such a great question. I really appreciate your asking that. And so I think there's a lot about nutrition in CF that we still need to learn. And we can look at other diabetes populations, I think, for some guidance. And we know that, a high sugar, high simple carbohydrate diet, it's just really hard for our currently available insulin to cover that and to prevent blood sugar from going high with those types of foods. And so in general, we really try to focus on like moderation of carbohydrates and then balance. So keeping the protein fat balanced with the carbs like you talked about. And I think that is easier said than done. So, but I will say that this is a field that I think, especially now that Trikafta is available, we really need to learn more about what should we be recommending, not only the quantity of calories, but the quality of calories that we should be recommending for our patients. I will say that we are going to be doing a pilot study in Boston where we look at a low glycemic load diet by a feeding study where we actually deliver the food as kind of the gold standard of nutrition studies, just over a short period of time to see that if it's safe, can we do this in people with CF safely? And then ultimately, I hope we'll be able to do larger studies to help answer some of those questions.
Thank you, Dr. Melissa. I think this next question will either be for Andy or Tony, if you guys could turn on your videos when you get a second. What would you imagine the insulin protocol would be for people with IGT?
So I can answer that one. Just what we're looking at in the study is 2 different ways of giving insulin. So we know that people with CF don't make a lot of insulin meal and don't handle the nutrients as well without insulin. So there's some rationale for saying, let's just give short-acting insulin before the main meals. But you can also give background insulin once a day. And maybe if your purpose is not so much to control blood sugar, but just to help build up muscle, maybe just having more insulin around all the time would help build muscle. So right now we're comparing 3 times a day rapid-acting insulin with meals and once a day basal insulin, and seeing what impact that has on muscle turnover.
Thank you. This next question, I think we'll go back to Melissa. What is the time frame for the bionic pancreas study, and how can someone that may be local or interested in those studies enroll in that study?
Thank you for asking that question. So we have had some delays related to various issues, the pandemic being one of them. And so we are planning to start enrollment on a short-term study that's only going to be like a week, 3 weeks total, much shorter term. We're hoping to start that study in August. We'll be able to get that one started, assuming that the pandemic is in a better place. And that's going to be single center, just in Boston. We hope that we'll be able to start that longer 6-month clinical trial, which is the one that we hope to bring to multiple centers. That could start maybe February of 2021, in that kind of realm. So stay tuned. So if you are interested, that would be wonderful. Please, you can reach out to me directly. Any way you want to contact us, that would be wonderful. If you're in the Boston area, chances are I already know you, but but that would be wonderful.
And I'd just like to add that if there's trials, I believe, that are multi-centered and funded or in partnership with the CF Foundation, if you go to cff.org/find, I think you can look up different studies that may be enrolling at different centers. This next question, I think, maybe for Tony again, are there plans for adding CF-specific diabetes educators in addition to increasing the training of endocrinologists?
Well, that is a really great question. And at the moment, there is nothing in the works. But you're right. We all rely on the diabetes educators for all of the day-to-day management. And of course, they play an integral role in education. So I think that's a brilliant idea for something that we should include in the next iteration of Envision.
And then I guess probably back to Melissa. Sorry, we're just like jumping back. Regarding the islet, how does that actually, are you able to avoid carb counting with that? And does it just affect the rising blood sugars associated with food intake?
Yes, that's a great question. So there's actually two answers to that. So yes, it does detect the rise in blood sugar that happens after eating. The other thing, it gives you the option of announcing a meal. So this is a normal meal for me, no reflection of necessarily the carbohydrate content, just the size of the meal. This is a smaller than usual, larger than usual, or typical meal. You can announce that, and the device will learn like what that means for you. So you can announce the meal if you want to. I will say that in our pilot, in the 3 adults with CFRD, most did not announce any meals and snacks, and it still controlled blood sugars very well. It's a great question.
Thanks. So the CF Foundation's current CFRD guidelines show that there's a loss of lung function for 3 years on average prior to diagnosis using the CFF guidelines. The question asks, shouldn't these guidelines be updated so diagnosis doesn't occur on average 3 years after lung function decline? And I think in the chat this was directed to you, Tony, but if somebody else wants to add, they're welcome to if you want to break.
Well, someone else can add on what I have to say, but I'll just say that's in part what my study was about, that when we make a recommendation like that, there is a sizable portion of people with CF who have abnormal glucose tolerance. And for us to say, now you need to start on insulin, we better be able to prove that they really do need to start on it. And that's why this study is so important. There's another similar kind of study going on in Australia. And so in part, the foundation is just waiting for evidence to show that it would really make a difference.
Thank you. And then maybe any of the pediatric endocrinologists, or if Melissa with the adult, there was a question about how do we help teens that are transitioning into college to kind of be compliant, maybe, as we sometimes know college students don't always do their recommended medication treatment, and diabetes on top of the CF is kind of a lot. So any recommendations or tips you may give? I can kind of weigh in as someone with CF and CFRD, and then I'm sure Michelle could also as a mom. I know for me, when I went to college and had to do it, it was learning the whole factor of how stress actually plays into my diabetes that I didn't realize. And it took me getting sick enough and realizing that I was getting sick because I wasn't actually maintaining and managing my diabetes for me to actually take it seriously. And I feel bad to say that, but that's kind of just, I guess I had to learn the hard way. And no matter how many times my doctors or whatever told me, it was like, well, I don't see that immediate impact. It was 6 months later when my blood sugar was out of control that I realized that, oh, maybe I actually should, check it more than twice a day and carb count and give myself insulin when I have meals, even if it's not the cool thing to do on campus. So I think for me, it was unfortunately learning the hard way, and thankfully most of that damage was reversible, but I don't know if that's good tips. That's just how it worked out for me. Michelle, did you want to add anything?
It is kind of a trial and error, and my son actually just graduated college, and so he commuted to school. So it was, more efficient for him to have all of his supplies and everything at home, and that did help. But we also kept in communication with disability services. So if you have kiddos that are getting ready to transition into college, even if they are commuting or whether they're on campus, and you probably know this, Megan, but the disability services will definitely be your support for all of that, and just help them if they need any type of services with their just CF in general or with the diabetes as well. But it was definitely challenging, and you just kind of have to go through it, trial and error. And it's great to see all of the technology that there's available today, with smartphones and these little electronics that attach right to the body. It's amazing, can make it definitely a lot easier than it did probably 10, 20 years ago. So we're definitely grateful for all the technology as well.
Great. I have, we're about 2 minutes, 3 minutes. So I'm just going to put this question out maybe for Andy or Bryn, since they didn't get to answer one yet. If you could just kind of talk about the role or the perception of how Trikafta has impacted your patients related to CFRD, or even just what you anticipate maybe finding and seeing, whether that's through the focus group or future research or anything like that.
Go ahead, Andy. This is right up your alley.
So I've been seeing effects in my own patients and have been talking with members of this group, as well as many other providers as part of the Envision group and outside of that. And I think it's quite variable. We've definitely seen lower insulin doses in a subset of patients. And for another subset, we've seen an increase in glucose requirements. And one can imagine that there are probably a lot of competing reasons for that. One may be, with decreases in inflammation, perhaps, some of us think that perhaps beta cell recovery may happen. And so you might be seeing lower insulin needs. But on the flip side, there's also some suggestion that perhaps intestinal health is improving. And as a result, some people's absorption of food may be better. So now they're seeing more food and their blood sugars are higher. In addition, I know of patients who are eating so much better on Trikafta. And so if they're eating better, their blood sugars may be higher as well. So I think it's going to be really hard to tease out what the various contributors are, but we're hoping that with these sort of nuanced studies that we're doing over the next 2 years, that we'll have some better insight into the direct role of Trikafta on some of these really important questions.
Thank you so much. And so we're at 7 o'clock, and so I want to be respectful of everybody's time. I just want to thank everybody that joined and attended and submitted questions before and during. I saw the chat was going crazy, so I appreciate that. This will be, this is being recorded, and it will be saved, and it'll be emailed out to, I believe, those people that registered, and then it'll also be on the CF Foundation's website. So if you have any questions, you can talk to or email the community voice, and they can probably give you more information. I'm sure the presenters might be willing to share their information as well. So again, thank you guys so much for joining. I hope you enjoyed this. I hope it was informative. And if you liked it, maybe we'll do some more. So